told me not to wander. So if I start wandering, I need you to like put your hand up so I don't become the wanderer. So I appreciate you coming out on a chilly evening to spend some time with us on this summer day. I'm going to be talking about pediatric oral health and fluoride varnish, as Steve made mention of. I'm a general pediatrician by training, and my area of expertise is in pediatric oral health. And I've been doing trainings across New York State, as Steve mentioned, but also nationally for the AAP. And I serve as the AAP's Chapter Oral Health Advocate for upstate New York. How many of you even knew that the AAP had a Chapter Oral Health Advocate for upstate New York? But there are only 3 of us in this state. 2 of them serve New York City, and then I get the remainder of the geography of New York State. So it's very helpful for me in trying to do my work in training and advocacy and policy creation if there are already community gatherings happening that are emphasizing oral health, because then we just can bring those 2 initiatives together. And tonight is an example of that. So I'm going to, without further ado, talk about oral health. And this is really about bringing oral health preventive services into the medical home, not just about fluoride varnish. Fluoride varnish is a piece of it. It's the piece that we get paid for. But it really is a bigger systems issue. And we as pediatricians and as people who work in pediatric offices, we are busy, busy people. And we want to do what's right for children. But we want to do what's right for children in the context of keeping our office functioning, be able to reimburse for services that we provide fairly, and be able to be certain that there is follow-up and that we can do these things correctly, we can do them well. So that's what this night is about, the beginning of that conversation. So I don't have any financial relationships. I have no money, therefore I have no financial relationships, and I'm not going to be discussing any unapproved products tonight. So there are my goals and objectives. They are on your evaluation, and I would appreciate it if you'd take the time at the end of this evaluation to circle all 5s, but to circle some numbers, and to really give us some objective feedback on what worked and what didn't. As the night goes on here, I'm going to do my PowerPoint presentation. At the very end, a local family has graciously agreed to bring their 2 children in so you can see the fluoride varnish demonstrated, which I think is very helpful other than just on a video. And then after that, we'll have time for Q&A, so that way if we run over time, people won't feel awkward about leaving, the circle. So I hope you had time to read those 7 bullet points, because I won't read them to you, but they are on your evaluation form. Really the big one, I think, from a systems perspective, is trying to figure out what factors keep kids healthy and what can we do to change those factors. That's really the conversation we're having tonight. So why oral health? I mean, of all things that I could talk about, all the things we could talk about tonight, why would I pick oral health? Why did the county of Jefferson pick oral health as when it's a topic? And he gave some really compelling data locally. But 15 years ago, Dr. David Satcher, who was the Surgeon General at the time, produced a seminal report called the Oral Health in America Report. And he brought up some really compelling points. He called oral health a silent epidemic in our nation because it affects poor people, young people, old people, so geriatrics and pediatric populations, and also those least likely to vote, so minority populations and low socioeconomic strata. So he brought that to our collective attention, and this was geared toward medical people, called oral health conditions collectively the most common unmet health need. Of all populations across America, oral health is the most common unmet health need. There are certainly oral health systemic connections, so the health of the mouth affects the body and the health of the body affects the mouth. So the mouth doesn't stand alone, it needs to go back into the body where it belongs, which means physicians, doctors who take care of people from top to toe need to at least know something about the teeth to be able to care for people appropriately. There are certainly issues of access to care, and we know that dentistry is one of the last remaining silos where it's very challenging, especially for very young children or people with special health care needs, to access dental care. There are huge costs associated with failing to do this poorly, and the irony of it all is it's largely preventable, and especially as it comes to childhood caries. It's very preventable if we could just do that which we already know. It's always in the doing. That's the challenge. So here are some oral systemic health connections. I won't go through that at great length, but suffice it to say that once the scientific community at large got a wind of the fact that there are some oral systemic health connections. There's lots and lots of publications and data on this, links with diabetes, links with obesity, links with pregnancy outcomes. Pick a topic, and in some way your mouth is probably related. And it makes sense, right? I mean, your mouth is one big old open mucous membrane with flora on it. And those bacteria are going to have effect on your whole body, and your body has your effect on your mouth. It's the gateway to speaking. It's the gateway to eating. If you have an unhealthy mouth, you do not feel well. And that was Dr. David Satcher's conclusion, that you're not healthy without good oral health. That's a really important point, right? People think they're healthy while they have a toothache. They can't get to a dentist, but I'm fine. You're not fine if you have rotten teeth in your mouth. You're not fine. And we need to figure out how to care for you, or better yet, prevent it from happening in the first place. Why is this important? I won't read you those things there, but it's relevant to small children. 25% of children in the low socioeconomic strata cannot access dental care. They just don't go by the age of 5. And certainly New York State has tried to do this dental certificate initiative, and I think that was a really important first step. But there's not a lot of teeth, for lack of a better word, a lot of teeth behind it, right? Because they can't keep you out of school if you don't have your dental health certificate. And I think kids should go to school, even if they don't have a dental health certificate. So it was an important step in the right direction, but it doesn't mandate something. And there aren't resources to mandate it, because we can't provide dental care for every single child. And then we're not going to not let them go to school. That's madness. So we made some important steps, I think, in terms of higher thinking, but we haven't fixed that access problem yet. And if you look at that bottom bullet of preventable dental conditions, it's costing about $2.5 billion. That's about $2.5 billion more than we have to spend every year. And the medical home, and I think those of you who work in primary care here will recognize this, we end up as a default dental home, because they come to us because they don't have anywhere else to go. And then we go, well, we don't really know anything about that. We kind of wish we did, but we really don't. And again, this is the beginning of that conversation. If you think about those small children, right, certainly many fewer people have dental coverage than they have medical coverage. Most primary care providers don't know how to do oral health well. We weren't trained in medical school, we weren't trained in residency, and we haven't been trained since we got out. So I really don't know anything about that, and I don't know that I need to know anything about that. And we do recognize that they are siloed, medical and dental. And I like to think about it this way. Most medical conditions are here in this big circle. So I try to keep children healthy by talking about, you know, riding your bicycle wearing a helmet, right? That's primary prevention. It's anticipatory guidance. I talk about it in hopes that you wear your helmet, and when you crash off your bike, that you won't get your concussion, and we don't have to worry about secondary prevention, preventing your second and your third and your fourth concussion before you end up like Mike Tyson, right? That's the logic of doing primary prevention. What we have found is that the last 50 years, we are waiting until children have dental disease, pain or cavities or holes in their teeth, until they access dental care, because the medical community isn't doing primary prevention. So we are drilling and filling our way out of a problem, poorly. Because once the tooth is cavitated, once it's already got disease, you're not going to fix that tooth. You might temporize it. And most of the time, you recognize children that have cavities in their baby teeth go on to having cavities in their grown-up teeth. Because what changed? Not much, right? It's not like all your teeth fall out in one day and you grow a whole new set of teeth. The healthy tooth comes in right next to a diseased tooth, and what happens? The whole process just leaps on to the next tooth. And certainly, dentistry does an amazing job of keeping those teeth healthy. But it's very expensive. For a lot of kids, it's not very comfortable or fun. For a lot of families, there are access issues. So trying to think about paradigm shift. How can we get more people to do this and really look on the big circle? Not to become dentists. Don't want a whole bunch of pediatricians with drills in their office. Totally out of our scope of ability. So thinking about what we can do here in this circle. Why us? So why primary care? I'm saying pediatricians, but when I say primary care in this context, I mean pediatricians, family doctors, nurse practitioners, PAs, nurses, anybody that gets to children first, right? That cares about the health of little kids. Parents who care about the health of kids, but this context is primary care. And when I say why us, that us is primary care. Prevention is what we do. We do it reasonably well. We're trained to do it. That's the conversations that we have. Put your baby on their back to sleep. You know, eat healthy, choose foods, things like found in nature, right? We have those conversations day in and day out. And we have a lot of access to very young children. In those first 36 months of life, we see them on an average of 13 times. That's 13. That's for healthy kids. Many more if they're unhealthy. So that's 13 potential opportunities to intervene and make a difference. Early childhood caries is not a hole in the tooth problem. It's a family problem, right? It's I didn't understand I needed to brush the teeth. I couldn't afford a toothbrush. I don't know what to do about toothpaste. I buy soda pop. I drink juice in my bottle to bed at night. It's a family problem. And so if you take care of the family, as we do in primary care, you can speak to it as a family problem, not as a kid problem. And certainly pediatric dentistry does this well. General dentistry does not do that terribly well. Oral health links to systemic disease. So thinking about, I mentioned, pregnancy and diabetes and heart disease. So we care about whole people, not just their teeth. And in most areas, the dental community is overloaded and not really increasing in capacity for the number of children that are going up in most areas. Certainly there are areas where there are enough or a surplus, but that's the minority. And I would argue that oral health goes with patient-centered medical home, which is where we're all moving, like it or not, right? Those applications, painful as they may be, right? We're getting there. And we're checking off the 17 check boxes. And so it's trying to make the applications for patient-centered medical home meaningful, right? Not just doing something to do it, but doing something that makes sense to help people to be healthier. So if we're going to pick a quality improvement, let's not just check a box. Let's improve something that actually matters to population health. And it's patient-centered, it's comprehensive, right? So oral health isn't just the doctor or the nurse or the PA or the case manager or the dentist. It's the whole systems thinking. And certainly it's an opportunity for the primary care to increase accessibility, to do something where we wait till they can get to the dentist. And that's the something we're talking about. And the AAP, so the American Academy of Pediatrics, has said you should. So since 2003, there's been a formal policy in place saying that pediatricians should be doing this. So every child should get risk assessments by the age of 6 months, and we should be talking about diet and hygiene. And this is all the way throughout Bright Future's very voluminous document, right, that we should be talking about oral health. And then the recommendations, which align with every other recommendation, is that children should be going to establish a dental home by the age of 1. That is truly the ideal. If everyone could establish a dental home, all children, by the age of 1, and get care regularly there, we would have a minimal problem. That would really be the perfect fix. We, however, don't have resources to make that happen in our current society, the way that our healthcare system is set up. So trying to think about what do we do when the ideal is perfect, but we aren't meeting the ideal, as opposed to saying we're going to keep only searching for that ideal and then keep failing to meet it. We have studies that show that primary care doctors and primary care associates can do this well. We can actually identify children. We can figure out who has rotten teeth. That's reassuring. And that caregivers are satisfied, so they're not like, you're not a dentist, you don't know anything about the teeth. If you are trained in it and you can talk about it eloquently or semi-eloquently or even a little bit eloquently, that the caregivers are fine with that. They're actually happy to have somebody looking at the kid's mouth and teeth while they're in the primary care office. They're there anyway for a variety of other reasons. The struggle has been around risk assessment, and this is a struggle in dentistry. It's certainly a struggle on the primary care side. How do we pick a risk assessment tool? Which one do we need? How long do they take? Which one of the data points really, really matter? And if I got to do 1,000 kids, do I really have to do this piece of paper too with the other 1,000 piece of paper I have to do per kid? So I'm doing thousands to the squared for every visit. And that has been a struggle and something we still continue to work on and try to improve. And importantly, I think that if primary care offices do begin doing oral preventive services, it doesn't mean they're not going to the dentist. If anything, it increases referral to the dentist of the high priority children. So it isn't like pediatricians and primary care people are doing this and then we like start owning the teeth. Precisely the contrary. We do it and we go, oh, that looks terrible. We should probably get them somewhere to get that fixed. But it's really a triage. Which of the 10 kids that I saw today really, really need to get there today? Who can wait 3 months? Who can wait 6 months? Who can wait a year? And what can I do in the between time to keep them healthy? Again, if they all went, that would be the ideal. I want that to happen. But it doesn't happen for at least those 40% of kids who have untreated decay in the 3rd grade in Jefferson County. Okay? So what are the rates of caries? We're going to talk about caries now for a minute and sort of the process of caries for those of you who are not dentists in the room. For those of you who are dentists in the room, like 7 years of training later, you should be giving this part of the talk, but you'll have to bear with me in my primary care hat. Caries is the process that results in a hole in the tooth. We call that a cavity. So the cavity is the hole. Caries is the process. Now I'm going to be using caries and only talking about the process. So it is, by any of those statistics, the most common chronic disease of childhood. 7 times more common than hay fever, 5 times more common than asthma. I talk about asthma and allergies, especially in April, May, and June, all day long in my office. Statistically speaking, I should be talking about oral health all day long in my office, and so should my colleagues. Early childhood caries is that process that results in a hole in the tooth in little kids. So children 5 and under. It is an infectious process that's caused by bacteria that's transmitted typically from your mother. And we used to have a bunch of nomenclature where we called it baby bottle tooth decay and nursing caries. The struggle with that terminology is it implied the route of delivery of the substance. It's really the fact that you're delivering the substance to the teeth that's the problem. So we renamed it all to put under this bucket term of early childhood caries so we could all think about it as a process, not as a delivery issue. In other words, nursing instead of baby bottle tooth decay may make a little difference, but you could get it either way if you did enough things incorrectly. And of course, it's affected by your dietary habits and your oral hygiene habits. And here's my favorite slide of all, right? A bunch of healthy babies with no cavities. But we still have to say, now 15 years later, now 100 years later, 200 years later, since the sugar epidemic began, that it's the most common chronic disease of childhood. It is an epidemic. It's an epidemic most places. It's an epidemic in Jefferson County. And if you look at some certain populations, low-income populations, between 30 and 50% of children have this process that will ultimately result in a hole in their tooth. And in certain subpopulations of minorities, you're talking about 70% or so. So if you add up all the total decay in all of children, 20% of children have the burden of the decay, 80% of the decay. What we need to figure out is who those 20% of kids are and fix them. The other 80% is going to be sort of okay, or they're doing okay in the system that we have going. They at least have some resources they can access. So these are a little hard to see with the lights, but you can just imagine what they look like because you've all seen this in your office. So early childhood caries, again, that process occurs as soon as the teeth begin to erupt. We typically see this pattern. Can you see here? These bottom teeth actually look pretty good, but the top teeth are pretty much just gone. Like no enamel, no white, no nothing, and above it is actually a little abscess. But here's the top teeth. So the canines, the pointy teeth, they look okay, but the other central teeth, they just look terrible. And that happens because when children suck in a bottle, the milk gets stuck underneath the lip there and kind of keeps the milk trapped, which is why bottles are such a risk. But the other reason is that the center teeth come in first, right? So they have longer for the sugar attacks to happen. And also the canines are relatively smooth, so it's harder for the plaque and the stuff to get stuck to them. And the bottom teeth are covered in saliva. And saliva is a great buffer for acid, which is what the bacteria make to dissolve the teeth, and also to help the food, the carbohydrates you get on your teeth, get washed away. And children are buckets of saliva, right? That's what they do. They make saliva and other output, but they make a lot of saliva. And so babies are drooling all the time, so those center teeth actually at the bottom do fairly well, where the top teeth really get obliterated. Those are the stages. So the first stage you can see here are these little white spot lesions along the gum line. That's the beginning. And here's the early cavity. That's the first stage of early childhood caries, is those white spots right along the gum line. This is what I hope and my dream for pediatricians and primary care providers to begin to recognize, because that is totally reversible. If we could do something, we could increase our interventions and we can make some changes in the family, we could turn that back many times to a totally healthy tooth. Or at least we can buy some time to keep it from getting to the second stage where the enamel's gone and now we're into the dentin, the yellow layer of the tooth. By the time you get to phase 3, now we're at a pulpitis, right? So that's an x-ray diagnosis. So now it's in the center of the pulp where the nerve and the blood vessels live. And 4, it's the same picture where the teeth are gone and now it's invaded down through the root and into the bone. And now we have a dental alveolar abscess. So now the tooth's gone, but now we have an infection in the jawbone in addition to just the tooth. So now we've let this go for many, many months or sometimes years, and now we're left with a much bigger problem than we had when we just had a little hole in the tooth or some white lines on the tooth. The struggle for us is Stage 1 and 2 are totally painless. So if nobody recognizes that this is a problem or they don't have access to care, it isn't until stage 3 that anybody's really crying for help, right? And anybody's really activated to help these small children. By the time we get here, it's the root canal, which is excellently fun in a 2-year-old, right? And incredibly expensive. They have to go to the operating room, or the tooth has to be pulled. Then you've lost that tooth, and baby teeth do matter. When I think about the pathogenesis, you have to have teeth. You probably could have guessed that. You have to have bacteria. I mentioned this is an infectious process. You have to have some form of carbohydrate. It doesn't have to be cola, but we can blame cola for all sorts of things. This is another thing we can add to the list of things to blame cola companies for. And then you do have to have some time. For some children, this is very aggressive, weeks, months. For some children or adults, it takes many, many years to develop a cavity of not that one area of the tooth not being regularly cleaned or not having a chance to heal itself. So there's a tooth, right? Just in case you haven't seen one today. The bacteria that we talk about, there are literally hundreds that are involved in the process of early childhood caries or caries in general. But we blame strep mutans sort of as a general category. And the important thing, I think, is that strep mutans is actually a good reflector of badness of the mouth, even if strep mutans isn't the only bad player. If you have a lot of bad strep mutans, you probably have a lot of other bad stuff, too, growing in your mouth. It's vertically transmitted, usually from your primary caregiver, who's usually your mother. So another thing you can blame your mom for if you have cavities. You do have to have some form of fermentable carbohydrate. So it doesn't have to be just good sugar or bad sugar. A Tic Tac is a fermentable carbohydrate, right? Bacteria don't need much. They're very small, but they do need some form of sugar. And it matters how often you eat it, not how much you eat. So certainly how much you eat matters for your waistline, your risk of diabetes, right, these other factors. But if you're going to eat sugar, eat it all at once and be done with it and brush your teeth right after. It's the sipping or the eating throughout the day that's really risky, and this diagram shows you why, and it's in your handout. Every time we eat, here's the arrow here, your tooth lives at a pH of about 7. Every time you eat, your pH drops down to about 4, anything less than 5, that red line there. The surface of your tooth begins to demineralize or become less strong. Every time you live over this magic red line, your tooth is remineralizing or becoming more strong. Every time you eat, you spend some time under the curve, anything or sip anything carbohydrate laden, and then we take some time, 20 to 40 minutes, for the saliva to do its job to bring you back up above the line. Hello. Those are our demonstrations. Thank you for coming. There are some risk factors. Many of them are obvious, so I won't belabor these points. But population risk factors are cultural issues and low socioeconomic status. If there's cavities in other family members, you might imagine that it's more likely you're going to have cavities also. Certainly feeding habits and hygiene make a big difference. And then as it relates to medical care, if you don't have saliva or you have other acid attacks on the teeth, it really does increase the child's risk. And there are some real consequences to having early childhood caries and having adult cavitation. They start with death. That's at the top. Death is bad, right? We want to avoid it whenever we can, especially when you're talking about little kids dying. And a lot of the momentum for early childhood carie transformation has been around the death of a child called Diamante Driver in Maryland. And there was this sort of legislative action that says we can't let children die of this. We had years to fix this kid before it went to his brain and caused an abscess, and then he still died. So death is bad. All the way down on that list of things, hospital costs associated with kids who have to go in for treatment of facial cellulitis or for OR time, very expensive to do operating room time, and certainly anesthesia risks. Those are some of the morbidity questions. And then down at the bottom are the costs that are really less tangible. I can't say it's $2,000 to go to the operating room, but how much is a missed day of school worth to a kid? How much is a missed day of work for a parent? If they're at risk for losing their job, a missed day of work is incredibly expensive. For me to miss a day of work, probably going to come back to a job, right? So how much is that worth to the individual? And a study done about a decade ago now showed that for early childhood caries alone, children miss 51 million hours of school per year, which means, of course, 51 million hours of work lost per year, because somebody's got to stay home. These are little kids now that we're talking about. So what about prevention? I made him, right? So what about prevention? So the things that we talk about, right? You know, the easy stuff. Start low, brush your teeth, right? Diet counseling, trying to get the bacteria not to go into the baby's mouth until later, because that just buys us some time for the process. We can talk about sealants, well, that's really not an early childhood caries thing. It's an older cavity problem thing. We're going to talk about fluoride, which is our focus today, and then certainly getting them to the dentist. And in the end, it is a balancing act, right? You're going to eat a carbohydrate in your life, but you could also brush your teeth. So it's thinking about what are the risks for that kid, what are the benefits for that kid, and what do we have at our disposal to try to keep children healthy. So brushing is easy, right? Relatively speaking. You do want to brush your teeth twice a day. You want to lift the lip and focus here for little kids. Cavities in older children are more of a molar problem like they are in adults, but in little kids it's a center problem, and it's relatively easy to brush the front teeth. You want to spit, but don't rinse because you don't want to wash that beautiful fluoride right down the drain, and you want to floss teeth that touch. And of course, if you've put toothpaste on your teeth that has fluoride in it to protect your teeth, then you don't want to eat and drink after that. There are some ways that you can brush your teeth. For very small children, I advise that you do it without the strangling piece because it's more comfortable for everybody, but the position is actually pretty good. Or certainly if there's two adults, you'll see me do this at the varnish. That's how we hold the children down to do the varnish in the medical home. Dietary counseling. So try not to eat a lot of junk, and if you're going to eat unhealthy foods, eat them infrequently. Right? So we talk a lot about the mindless snacking problem in America. Right? It also, in addition to making a higher risk for diabetes and obesity and all this other stuff, it also is a high risk for cavities. You want to eat things that are not terribly sticky. So, you know, raisins are an okay food, but they stick terribly to the teeth, and young children don't clean off their teeth very well. Things like fruit roll-ups, which is not a fruit, it's just a roll-up. We shouldn't call it a fruit roll-up. We should move it out of the aisle that is in fruit because it's not a fruit. It doesn't even resemble a fruit. And so we have to talk about these sticky things. Other things that we can do, I'm going to focus the rest of my time on fluoride because that's our kind of our focus here today. If we're going to talk about fluoride, fluoride is very safe in appropriate amounts. There's lots of angst about fluoride on a local level, on a regional level, on a national level, the whole world. Fluoride, like most things, if you use it appropriately, is very safe. So what we want to do is figure out what does appropriate mean. Fluoride has a couple effects. There are four there. Of the four effects, the enhancing remineralization is the most important part, right? So it makes the tooth, the enamel, the white part of your tooth, stronger, harder for the bacteria to break down with their acids. And if you're going to argue a point, the topical effect of fluoride is more important. So if people don't want to eat the fluoride and swallow it, I don't care. Put it on the surface of your tooth and spit it out, because you're going to get 90% or so, 80% something of the effect of the fluoride just by applying it to the surface of the tooth. It'd be good if you had a little systemic, but the topical effect is the most important. There are a bunch of ways you can get fluoride to people. Certainly community water fluoridation is one of them, and it does work. You can do systemic supplements if children don't have access to community water fluoride. You can do the easy thing like toothpaste, and then you can do things like topical. There's a bunch of topical options. Varnish is what we're going to focus on today. So community water fluoridation, there you go. You can find out about your counties by going to My Water's Fluoride from the CDC. Here's New York's fluoridation. This is a relatively old graph, but it hasn't changed much. Fluoride sources, right? Fluoride toothpaste makes a lot of sense. It's cheap, it's easy to apply, and it has the advantage of making it more likely you're going to brush your teeth. Because people just don't go around and put toothpaste on their mouth. Well, some little kids do. But most people put it on a toothbrush and they have the mechanical action. So you get the mechanical action of brushing and removing the gunk off your teeth, the bacteria and the sugars, plus you get the fluoride effect. And then you can do mouth rinses, but only for older kids. New recommendations from the American Academy of Pediatrics is toothpaste for everybody from eruption of the teeth. There was all sorts of guidelines. It was very, very confusing. Who gets toothpaste when? We don't know. Some, maybe a little here, maybe a little there. So recommendations from American Academy of Pediatrics, the American Dental Association, and the American Academy of Pediatric Dentistry says fluoride for everybody from eruption of the tooth. But a little bit. So a smear, like not Aquafresh, right? A little tiny smear. And I say that to explain it to families as a grain of rice. Because most people understand the amount of a cooked grain of rice, a very little bit. And when we get to older children, we're talking about a pea-sized amount. So after the age of 3, green pea-sized amount for everybody. In 2009, Medicaid saw the light and began to reimburse medical providers for application of fluoride varnish in the medical home, which is what we're talking about here today. The initial recommendation was to use the dental code, D1206, which was great, but a little bit confusing, because primary care people weren't used to using dental codes. So we were like, what's a D code? I don't know, what's a D code? Is it in CPT? No, it's not, right? And it was a little bit confusing. So now we're moving in another direction. But in the last 7 years, and largely due to the efforts of the Pew Foundation, we've walked across the United States, and now of states, Medicaid and Medicaid managed care reimbursed for these services in 46 out of 50 states. So that was a huge policy change to get Medicaid and Medicaid managed care at the federal level through the states to begin reimbursing for these services in the medical home. And part of that was on the heels of the Into the Mouth of Babes program, which was a North Carolina program, and it was really ahead of its time. Essentially, a whole bunch of people got together and said, well, if we can't get them all to the dentist, who can we get them to? And they came to the conclusion that, well, primary care providers can do this if we train them. So they took under a mass initiative, and they trained basically every primary care provider in North Carolina, right? 6 or 7 years ago. And it turns out if you train primary care providers and they do it well, it actually prevents disease. Well, that's encouraging, right? But you have to do it for a lot of kids, and you have to do it really early. So if you wait till they're 4, 5, 6, 7, 10, 12, you don't prevent disease. They already got disease if they're going to get it. If they don't have it by the time they're 12, they're probably not going to get it, right? So it's really these little kids, and these studies showed us that if we're going to do it, we really got to start with the 12-month-olds, the 9-month-olds. Start getting in their mouths and having these conversations and applying fluoride varnish. And then the high-risk kids, ship them off to the dentist as soon as you can, right? And let the experts do their thing. So we're talking about a 17 or an 18% reduction in cavities across the state of North Carolina. That's huge. That's on the order of millions of dollars saved and health improvements. And if you looked at multiple treatments, so not just varnish alone, but also hygiene conversations and getting them to the dentist, the rates were closer to 30 or 50%. So 17% sort of like the minimum if we do bare bones, but we might be able to get 30 or 50% improvement. And especially if we do the littler kids. So if you're starting at 12 months and you're really gearing 12 to 24 months, that's where you're going to see those huge reductions, long-term savings. And the United States Preventive Services Task Force, say that 5 times fast, USPSTF, last year in May of 2014 said, thou shalt. This was huge for the pediatric community. They came out with a formal recommendation, which was a grade B recommendation, which means that it has to be covered by the ACA, has to be covered by private payers, that all children should be varnished in the medical home 0 to 5 years of age. So this was a huge policy push, right? Because you go and ask your average primary care doctor, they're like, what's fluoride varnish, what's a tooth, right? And we got to go back and figure that piece of it out. So these initiatives are part of bringing these recommendations to light and kind of put them to some sort of action plan, besides just here's a recommendation, do something, right? And what does that really mean? The sad thing that they didn't do was they didn't say how often. So they didn't say 4 times a year. They didn't say 2 times a year. They didn't say once a year. They just said you should. Well, I should what? I should varnish. Well, how often should I varnish? So then it becomes a conversation about who and when and how am I going to pick. If I have to do it for everybody, do I have to do some for once a year and some 4 times a year? And if so, how do I pick? And that's a real struggle in terms of creating an action plan. So the American Dental Association fortunately had some guidelines, as did the American Academy of Pediatric Dentistry, and they recommend every 6 months through age 5. Now that's a dental recommendation, but you could extrapolate that pediatricians could do that, right, every 6 months, so at least biannually, and for children that are higher risk up to 4 times per year. And that's what the American Academy of Pediatrics came out and said. So in their September publication in the Journal of Pediatrics, the recommendation was that all children, irregardless of risk factors, should be varnished every 3 to 6 months in the medical home. Higher risk children, however one defines that, should be 4 times a year. Lower risk children should be biannually. So that's every pediatrician, every child 0 to 5. That's a huge system shift that we now have to figure out how to accommodate. On the upside, fluoride varnish is safe. It's easy. It's been studied forever, and it's shown to be very safe. Certainly Europe kind of led the way, and now we here are kind of figuring out how to do this well in the United States. It strengthens your teeth, and it reduces cavities around that 30% number. That's what we're aiming for if it's done well. Certainly if you talk about healthy eating and healthy drinking and don't just paint the teeth, right, that's going to make a much bigger impact than if you're just slapping paint on everybody. That doesn't make any sense, meeting them at the door of the varnish and sending them on their way, right? You got to talk about how you keep your teeth healthy. This is a piece of that. It can be used on any erupted tooth. It can delay the progression of cavities. It is safe. You do swallow a little of it, right? Because, of course, if it goes into the mouth, eventually it's going to go into the system. But they swallow very little of it compared to the amount on the thing. There are minimal or no contraindications. We don't put it on open wounds because it burns. So if there's an open wound in the mouth, like an aphthous ulcer, we don't put it on the teeth. And then children who have a known allergy to colophony, we wouldn't apply the fluoride varnish, which is, number 2 question I ask, like, what's your address and do you have an allergy to colophony? What does this entail? So I have to do some sort of risk assessment according to the AAP, although USPSTF said, on a risk assessment, varnish them all anyway. So really, I don't have to do this anymore. But if I could use a risk assessment, I could do it because it might help me to tailor my guidance so I'm not just saying everything to everybody. Right? The concept behind motivational interviewing, what are you willing to change? And then let's talk about that topic instead of me, a litany of 27 things I want you to do different by 15 months of age. Because those 27 things aren't going to happen. I'm lucky if 1 happens, maybe 2. So let's talk about what works there. You have to do some anticipatory guidance around healthy eating, healthy drinking, or otherwise you're just painting. You should do the fluoride varnish itself, and of course you should try to get them to a dental home, right? That's where we want them to go. Get them to the specialist and let them do their thing. And document what you did, because you have to do that. There's a risk assessment tool by the AAP, and you can find all of this information at the very end of the guidelines. There's a AAP Oral Health Home address. The AAP Oral Health Home has every documentation you could possibly think you might ever need to help you to begin to integrate this in your office. So here's an example of a risk assessment tool that you could use. I'm going to do fluoride varnish in my home, in my medical office. I don't do it in my home. In my medical office, for little kids and for older kids, I lay them down on the examination table. But what you're going to see me do here today is the knee-to-knee exam, and I do that for all infants and toddlers. This can be delegated to office staff members. It doesn't have to be the clinician that is doing this, although in our office, the clinicians do it, and partly because we're a resident training center. So we want to make sure that our residents are competent to do all the procedures before we send them out. But that's an office-based decision. And the reason that it's great to have the parents do it is, 1, then they're holding the child, right? So the child's less afraid than being held down on the examination table. 2, you already have a natural holder, so I don't have to call in an office staff person for all of them that scream and flail, which is about 99% of them. And I can get it done and explain things while I'm going along to a parent who's standing there listening, or 2 feet in front of my face. Here's an example of it being done, right? And the question always comes up of, do they bite? Yeah, they bite. So you have to be real careful where you put your fingers. But fortunately, most of the time, you're propping along the molars, and they don't have molars yet because we're gearing toward very small children. So important things first, right? You got to do an exam. You got to look everywhere. And you got to see what you can see, and you got to figure where you're going to put the varnish, and you got to apply it all. The whole exam takes about 30 seconds, and I do it while I'm applying the varnish. The varnish takes about a minute. Again, you're looking for these white incipient lesions along the gum line. Those are the first stage. We want to catch them, we want to reverse them, and we want to have them go back to a healthy tooth. Varnish is a way to do that. And here's a video about applying fluoride varnish, and then you're going to actually see it on a real person.
When applying fluoride varnish, you want to get the child in a safe and comfortable position. Turn the child around so she is facing her mother. Tip her back onto your lap and place her legs around Mom's hips. Mom should hold her hands. Julia has no back teeth yet, so we will only need to apply the varnish to her front teeth. Dry the upper front teeth with gauze and paint on the varnish, covering all the teeth. Try to keep the tongue out of the way with your fingers. We're using cavity shield varnish here. Young children often cry when this is done, but this means their mouths will be nice and wide open. Now dry and paint the bottom teeth. Here, it would be helpful to use your finger to keep that tongue out of the way. When finished, clean her face and sit her up. Older children have more teeth, and you will have to start by applying the fluoride varnish to the back teeth. Dry the teeth in the upper left corner of the mouth with the gauze and paint on the fluoride varnish. Be careful to hold the tongue and cheeks out of the way. In this case, we're using Enamel Pro varnish. When finished, move down to the lower left corner of the mouth. Again, dry the teeth and hold the tongue and cheeks out of the way and paint on the varnish. Move across to the right side and do the lower and upper corners of the mouth. Frequently, we do not do the lower incisors as they rarely get cavities. As you paint on the varnish, make sure you cover all the tooth surfaces. Once the varnish is on, you do not have to worry if it gets wet, as it sets on contact with saliva. Paint the upper incisors last, so that you do not accidentally wipe off the fluoride varnish as you work in the back of the mouth.
So that was quick, right? That's even with an explanation. And at the rate I talk, it's about half that speed, right? Ignore that part about don't paint the bottom center teeth. If you're in there, paint them all. Like, why would you not paint them all? And you'll notice that, this is a professional dental application. It is not Picasso, right? You're in there and you just put it on as surface as you can and you're going. The surfaces do need to be as dry as possible. So you do want to make sure you get gauze. And the gauze, when you use the gauze to wipe the teeth, the nice part of it is it does remove some of the plaque or the most recent meal. So you're applying it to a drier, relatively cleaner surface. There are offices where they clean the teeth first, or they use toothbrushes. From a time and logistics perspective, I don't do that. I apply the varnish to the cleanest surface I can make happen with the tools I have at my disposal. Important things about varnish is children can eat or drink right away, so there isn't a huge delay. We do ask that they avoid hot and very sticky foods, but small children don't eat a lot of soup and peanut butter, so it becomes irrelevant for most children pasta-laden diet. You don't want to brush that night because you want to leave the varnish on that evening. You want to resume your normal in the morning. And for that day, if you take a fluoride supplement, you would skip it because it's presuming you're going to eat at least all of that varnish that was on the teeth eventually. So why double the fluoride dose in case there is any risk of fluorosis? So how do I decide how frequently? Well, the American Dental Association, as I referred to earlier, says every 3 to 6 months. The American Academy of Pediatrics says the same thing. The AAP says every 3 to 6 months. USPSTF says everybody, but we don't really want to say how often. We don't want to commit to a time frame. So I would say, from a logistics perspective, if we got to put all of that together, you aim for a minimum of 6 months, and any child that you deem to be high risk based on a risk assessment or something else clear clinical judgment, you could be doing a 3-month interval for high-risk kids. What are the barriers? And we just have to address them head on, right? There are barriers to starting anything new or different. The biggest one is time. And then the second one is disinterest, which usually masquerades as time. Because nobody really says, I'm disinterested. We say, I don't have time. I have time to do a whole lot of other things, or I make time. So it becomes an issue of, this is a huge public health problem. We have the ability, we have science that shows it makes a difference, and relatively easy interventions we can be reimbursed for that really do lower the burden of disease. We have to talk about, the impact of failing to do this well. We're paying the consequences now for failing to do it well for the last 50 years. Let's see if we can make a difference in our lifetimes. The other thing that's helpful is the messaging that we are already giving about healthy eating and healthy drinking. It's the same messaging. And that's a lot, right? Because then it's not double talking. And do I really care? I said this last week at the Dental Foundation meeting. If somebody quits smoking because they want to be attractive or they don't want to get cancer, no, I care they quit smoking. Do I really care about your motivation? Not much. So if the motivation is to be healthier or not to get high blood pressure like your parent or not to have more rotten teeth, then we launch on to that. That's the motivator for change. And then we make the move from there. If your motivator to change is not having another cavity and having to go the drill again, then let's talk about the juice in the bottle and whatever the other issues may be. Unfortunately, it's not someone else's job. Guidelines are saying it is our job, and we got to figure out how we're going to own this with the least amount of pain. The reimbursement issues are getting better. You know, Medicaid and Medi-managed care for 6 years have been reimbursing for these services, and the private payers are having to come along, kicking and screaming, but they're coming along. And is it going to matter? Yeah, we do a lot of stuff, right? That doesn't matter very much, but studies show us that this does matter. And there's always some questions about families don't want to talk about it, right? They don't want to hear about the teeth from me because I'm not a tooth specialist. But they hear about everything else about health from you. And when this becomes part of our normal conversation, it won't feel so awkward for us or for them anymore. We talk about all sorts of even more awkward stuff, right? Especially after the age of 12. So the teeth is relatively safe compared to everything below the belt line, right? In terms of awkwardness. And it relates to the messaging. We do have to talk about baby teeth. Teeth do matter. The analogies that I use are slime and time. So this is how I talk about it with family. It is an issue of slime and time. We can't fix time, so we can fix slime. How are we going to remove it? How are we going to get it off? How are we not going to create it? That's the conversation that we use. If we talk about bad, evil bacteria that are eating away your kids' teeth, it's terrible, right? Then the bacteria are to blame, and all we're doing is fighting the bacteria together, as opposed to you are to blame because you're an incompetent parent. That's a terrible message. Nobody wants to feel like they're to blame, right, for something that happened to their child. But they have to believe they can make a difference, or otherwise it's going to keep happening again, and the next tooth or the next kid. And then I talked about, you know, choosing healthy eating and how do we make that change. And as everything else in pediatrics, everything else in life, concentrate on doing one thing different each visit and add on. The billing people came for this. In order to do billing for Medicaid, you do have to do some form of risk assessment, although writing high risk counts. You don't have to tell them why. You just have to say high risk. Anticipatory guidance, I got to talk about something like getting healthy. I got to apply fluoride varnish, and I have to make some effort to refer them to a dental home. The effort can be as simple as what you are already doing, which is giving them a dental sheet, right? Saying, here's a list of the local dentist. Now, I would argue we really have arrived when we case manage dental like we do every other part of the body. Right now, I send a child to a cardiologist. It's my expectation that I'm going to get a letter back, and it's the cardiologist's expectation. They're going to know why I'm sending them. We don't do that for the teeth. We're like, oh, go find a dentist, best of luck, right? And then next year we ask you, did you see a dentist? No, oh, surprise, right? Because the kids don't have this case management, this referral coordinator, social worker, somebody helping them to do it. We really have arrived when we do that piece of it. Medicaid, their dollars 4 times a year, birth to age 7. They do not specify in particular who could do the varnish or any particular training. The private payers, Fidelis, has required specific training, and you can hand them the certificate. But prior approval is not required. Those are the CPT codes. So this is a code in January that came out. So before we were using a dental code, D1206. Now we're billing on the medical side. So for anybody that's medical and dental, if I varnish today in my office and they go to the dentist tomorrow, the dentist could still do it. I doubt that they would, but they certainly could, because they're 2 totally separate pots of dollars for the private payers. For Medicaid, it's the same set of dollars, but they're delved into differently. So we don't end up sort of bumbling over ourselves trying to figure out who did what when to make sure everybody's appropriately reimbursed for the services that they provide. I have found that applying the V modifier helps very much with some of the private payers. And the modifier that we use is V0731. That's the ICD-9 code. I don't know what it's going to be in ICD-10. And of course, if they already have caries, well, then you can use the code for caries. And it doesn't have to be totally obliterated teeth. It can be those white spot lesions if your clinician's willing to use that diagnostic code. And because sometimes it helps if you link that code with one of the other codes in terms of being reimbursed. And the last thing I'll say before we varnish these very patient children in the back is that we can do more than just varnish, although varnish and, and talking about healthy eating and drinking, there are other places where our voices, so the voices of primary care doctors, can make a real difference for oral health. And there's already this whole county-wide agenda, and there are very, very few medical people sitting on that. So of our voices, which are powerful voices, how can we activate those to make bigger impetus changes? And the people sitting at the table are the Head Start people and the school-based health system people, the FQHC people. So, more medical people, primary care people we can get in that conversation, the more dental people we can get into that conversation, the more likely we are to make system-wide practice changes for the community. And There's a list of resources. I mentioned the Children's Oral Health Home at the AAP. They have a great amount of fabulous things. And some of the things that they have are, where do I order fluoride varnish? Who's the manufacturer? Who's the dental supplier? How much does it cost? Where do I get toothbrushes? Where do I get varnish and mirrors and that sort of thing? So they have resources on that, so that way you aren't going around searching Google for how do I order fluoride varnish in my home. Somebody's already done the legwork and put these resources together for you. And that's, if you just Google AAP Children's Health Home, it's very easy to kind of navigate through. There are also some additional training modules on more of this. If you didn't feel like today got you through it, or you needed more, other providers in your office needed something to kind of help them buy in or get it. Smiles for Life, if you Google Smiles for Life, it's the first thing that comes up. It's an oral health curriculum across the spectrum of life, but certainly 2 of the courses are directed at children alone, and 6 is really about varnish. And then AAP also has another module. Do you see the Apple kid? He's familiar, right? Has a module that's much more in-depth, pediatric oral health across the spectrum, so much more in-depth than Smiles for Life is able to do. And there's my email if anyone wants to, and I'm going to take this opportunity to varnish these 2 very patient children here and show you guys how it's done. And then we will take Q&A. You guys are awesome. Hi, Melinda Clark.
I'm Carly.
Nice to meet you. And who's this guy? What's his? Jimmy? Jimmy? Everybody, this is Jimmy. Can we give Jimmy a round of applause? Jimmy's a Star Wars fan. I'm going to need a second pair of gloves. Look at those teeth, right? So Jimmy is a Star Wars fan, which increases his kudos by about a 10-fold. So you can see all you need. These are regular 2x2s that we use in our office. I use a headlamp, 1, because it increases my coolness factor, and 2, because it gives me a free hand. What I'd ask you to do, if you will, is actually put him right in your lap, like he's going to give you a hug, facing you, straddling 1 on either side. And all we're going to do is look at those teeth. Yeah, 1 on either side. There you go. Looks like you've been out with the bugs. 'Tis summer. It's a beautiful thing. Okay, so I wear my very uber cool headlamp. I get my thing. I get my varnish ready. This is really logistically this simple. I mix it up. I put it right in here in my snuff box because it gives me 1 less thing I have to do at home. When you have very cooperative kids like Jimmy, it's a total non-issue. Here we go, Jimmy. Can you come right down in my lap? Oh, aren't you awesome? You want to see my lab? You can wear it after we're done. How's that? Can I see those teeth? Show me your teeth. Can you open up big enough? Oh, my goodness. All right. Are you a dinosaur?
Yeah. I got dinosaur teeth.
You do. Can you be a non-biting dinosaur for the next 20 seconds? All right. Awesome job. Now open up big and wide. Open up big and wide. You are the best kid ever. Look at you, Jimmy. Open up. Good job, right? Good job. I know, doesn't it taste like strawberries and cream? It's awesome, right? Open up. Got just 2 more sets of teeth to go. Here we go. I try to throw my stuff on the floor whenever possible. And open up for me, big. And the last quadrant. Open up for me, big. All done. You rocked it. Can we trade for sister? Does she have any teeth?
Yeah, she's got 6. 4 on top, 2 on the bottom.
So I'm just going to show you how to do it for sister. It's very similar with the littler ones. Jimmy was incredibly cooperative. With the littler ones, you showed it to me. It's the light, isn't it? It's pretty fancy. With the littler ones, you can actually just do it sitting up, because sometimes they get a little weirded out. Let's try to turn her around. She's a pretty happy little girl. I bet she'll do it.
Are you jinxing me here?
Nope. Hi there, because I got the lamp. So what you're going to see is Mom's going to need to hold the arms right across the chest, just like that.
Good girl.
I told you she's going to rock it.
Here we go.
Is she violet?
Yes.
And she has a violet
Yeah.
shirt on?
We do
I
that
am in
sometimes.
love.
Well,
Totally in love.
red hair,
Right?
blue
So
eyes.
here she's only got 6 little teeth. So I'm going to prioritize the upper center teeth because the bottom teeth are less likely to be affected. And that way, if all goes down the tubes, right, I can probably still get these front center teeth done.
Wow.
Right?
Good job.
Yay for Violet! You rocked it and a pound it. Rocked it. Oh, wait. Boom. See, what did I say? And this was at the witching hour. It's bedtime. What was that? Oh, of course you can. You going to wear it on your head? Okay, just checking, because you never know. All right. There you go. You show everybody? You know, for spelunking and stuff and things. All right. Okay, questions? Yes. So you can actually choose the product that you like. I brought some examples of products that's not in any way, because I have a preference of a product. The one that I used is flavored like cherries and cream, strawberries and cream. There's cherry flavored over there. There's a bunch of different types of flavor. You can just sort of pick what you want. I found that the fruit flavors go over better than the minty flavors with littler children. But I brought some over there. They're all expired product. So don't use it, but you can go look at the product, you can taste it for all I care, and you can see which one you like. I also brought over here, for anybody that's interested, you want to bring back the AAP created a flip chart about oral health, which is an educational tool that you can use for families in the office. And on the front side, you'll see that it talks about teething, and it talks about healthy early childhood caries, and we get to information about varnish, so you can kind of talk about what is varnish about. And on the back, it tells the doctor and the primary care person what to say. So that way, if you don't know anything about it, you can still blunder your way through it and look remotely competent. And it gives like pictures, so people are, well, they're kind of figuring out what is this about. And there's one for each of you to take back to your office. It's compliments of the AAP. And in here is a little guideline about oral health, and it includes information about trauma and primary prevention, those types of things. So it's just a little something that you can have to help kind of begin to integrate these services in your office. There is also some information from the Maternal Child Health Bureau. I use these pamphlets where I give them to families with the anticipatory guidance. You can take the ones that are here, but they're free, or you can download them as PDFs. And they're nice talking points because they're check boxes for families. So you can say, well, you're already doing this and this and this so well. What about this? Can we make this one our time? And you'll give these to families. These are all free from the NCHB. And I do these sometimes. You're welcome to take one as an example. These are flavored sticks. For the bigger kids, where I need to move the tongue out of the way. So as opposed to the stick that they loathe, right? The brown stick that you do for the strep swabs, I use these sticks for the oral health risk assessments for my examinations, for my application of varnish, because it's new, it's different, and it's novel. And I've gotten some of these things donated through some of the bigger companies when I order varnish. So something that you could be thinking about, and then you're welcome to look. And I gave you the example of the headlamp. Again, none of these are proprietary. These are all just things that I've found along the way that help make my job easier. The last thing for those of you who actually are on the ground figuring out systems issues, the biggest change in getting my clinicians to do this well was to put all the stuff in a bag, like a Ziploc bag, as opposed to them having to run around and find the gloves and the gauze and the thing and the stick and the mirror. Whatever they might need, we put them all in little throwaway sandwich bags. And then we waste a lot of sandwich bags, but we can reuse them. But that way they just walk by. And the residents now, they're going in to see a 2-year-old, got my packet. They're going in to see an 18-month-old, they bring their packet in. So they have to go out, find their stuff, and find their way back in. They do it just as a part of their examination. So the little tips you learn to try to make it less cumbersome and closer to that 1 to 2 minute margin to get it done. If you waste 3 minutes finding stuff and it takes you 30 seconds, well, that was 3 minutes you didn't have and 30 seconds you could probably afford. Any other questions? Did you have a question?
Yeah, when you said something about you could train anybody to do this, anybody in the office, I thought when I looked it up in the AAP it said it had to be an RN or above.
So that's an interesting question. The AAP doesn't have a formal stance on this.
Okay.
The AAP says that somebody should do this in the primary care office. Medicaid said it could be delegated to anyone, so Medicaid did. So an LPN and RP, an RN or an LPN, I'm going to get them straight, or a medical assistant, that was Medicaid. I have a sense that when the private payers start doing this more often, that they're going to require it to be done by a clinician, and Fidelis has come out and said that. So the billing provider, so the physician, the PA, the nurse
It was
practitioner.
Fidelis. One of
It's
the examples
Fidelis.
we
It's
had was
always Fidelis.
Said an RN.
Does Fidelis watch this webinar? I hope not. They're going to get me. It's often Fidelis who has, sort of subset criteria to make things.
It was.
To make things clear. Just to make things. Anybody else have any other questions?
Are you finding any of the commercial payers are reimbursing for this?
Actually, I would 9 out of 10 of my payers are reimbursed.
Okay. Based on medical need and documentation?
Based on them being kids and having teeth. Yep. So,
Who's 10?
I'm just not even going to say it. Because it's actually an Albany plan, so it won't matter for you. I doubt it's a plan that you have in the area. But the Blues are reimbursing, and Fidelis is reimbursing, as Fidelis does. What I think is going to be the struggle is how much they're going to reimburse and for who, and are they going to still use this D1206 or can they use the 99188 codes? And I think that's still remains to be seen. What we've done is put it in as part of our advocacy as we have our ongoing conversations with payers, how much, how often. We send out queries this like we do many other things. We added it to our query list. Are you going to pay for this code? How much? Do we have to do anything special? Do you need a D modifier? Those types of questions.
Right.
So that would be something that would be worth doing in the area, perhaps thinking about one person doing that and then letting everybody else benefit from that effort. Yes.
I checked, I work in Fort Drum, and TRICARE will not reimburse for fluoride treatment, and they're a grandfathered plan, so they don't have to follow the ACA requirement.
Yeah, I wasn't going to throw TRICARE under the bus,
Well,
but Lorraine actually did a lot of that work, and the only one that came, where's Lorraine? Yeah, sorry. Can you speak to locally in the area? You did some of this effort.
Right. The two that come up are, well, there's 3, and you've already spoken of 2 Fidelis, which they do pay, but there is criteria, but if you just follow the criteria, you get some reimbursement back from them. TRICARE does not, as she said it perfectly. They're grandfathered in. And the St. Lawrence County school, that they do not. And the reason is they're self-funded. And so the self-funded programs do not need to follow the state mandates as some of the commercials. So if you're looking at other self-funded programs, then you might want to ask that question. But in terms of the ones with the JPO, I'm sorry, I'm Lorraine Clement, the Executive Director of the Jefferson Physician Organization, and so therefore I checked with the payers that we contract with on your behalf. And so of those, that was the ones that did not. The others had some form of reimbursement and some criteria. It's, as with every benefit, it's payer specific.
Any other questions?
Yes. On the dental limited, so we do not have to try to figure out what the physicians are doing to make sure that we're still able to do our 4 times a year.
And how you would do that,
I know.
if you wanted to. Yeah,
I know.
I can't, there's 2 pieces to think about. One, there's the payment issue, and that's real, right? And now that we are billing 2 different sides of the fence, we should not be double billing. We shouldn't be concerned about that. There was actually a real risk when we were using the D1206 code. Although so few physicians were doing this, it almost didn't matter, and they were almost always doing it to kids who couldn't get to a dentist. So there's that piece, and then there's I think the real piece that we ask ourselves, which is the safety question. And if you went and you got your varnish at your pediatrician in the perfect world that we live in, and they went at 12 months and 15 months and 18 months and 24 months, and they got varnished 4 times in my office, which might not happen, but let's say it did. And then in between there, they went to the dentist 2 times. So we had a 2-year-old who went to the dentist twice in a year, and their pediatrician 4 times. Theoretically, they could get 6 varnishes.
Is 6 varnishes bad? Probably not. And the majority of children, we don't think there's added benefit to additional varnishes, but there's also minimal added risk. You're not going to get fluorosis of your grown-up teeth from 6 varnishes in a year. I'm not saying we should be cavalier and varnish everybody every week in a year. Why would we do that? It wouldn't make any sense. But it is safe, use an appropriate amount. And I think the idea that children are going to get it 4 times in the pediatric office and they're going to get it twice in the dentist office within a calendar year is almost laughable, because most people don't receive those services. And the people who do have those types of services are people who are going to say, I had this done last month in the pediatrician's office, I don't feel we need it again. Those are the people who are going to be able to say, we don't need this or we don't want it at this.
And couldn't you put that in your risk assessment?
You absolutely
could. Was the
could.
last time you saw a dentist?
Absolutely, and it is in the risk assessment.
Okay.
It is.
And who is your dentist?
Yeah, it's actually whether you've seen the dentist in the last 6 months. It's part of your risk assessment. And the AAP has this formal risk assessment tool, which I'll make a plug for, is about to be out on an app next month. And the Smiles for Life is putting out an app that has the risk assessment tool integrated in the app, so you can do it electronically. You can't obviously document that way, but it might be an easy way to sort of learn it. It's a very simple tool. Once you've done it 5 or 6 times, you don't need the tool anymore. But it's very helpful, I think, to educate people. I don't scan it or anything crazy, but it is helpful in terms of learning the criteria, especially for people who are being trained about oral health. What do I care about? If I'm going to pick 5 things, which 5 things should I pick to ask about? And that's, to your point, that's an important question. And if there are 5 things and only 4 of them are fine and one's the red flag, well then the red flag is what I need to spend my time and energy on trying to risk reduce. Any other questions? Yes, sir.
You have a youngster coming into your office and they're high caries risk, and you apply the varnish. And what else are you doing now to encourage them to find a dental home other than go find a dentist?
So me?
Or how do you follow up with it? Well, you or I guess maybe the other physicians here in the room.
We hand out your toothbrushes.
And we appreciate that.
And that's what I was going to say, because I just left Teresa Primary today. I think there was 200 and some odd kids. And every classroom that I talk to, I say, does everybody, raise your hand if you've never been to the dentist. And some of these kids are telling me that they don't even have toothbrushes. Yeah. So we dropped off toothbrushes, and if anybody needs them,
we usually have
tons of toothbrushes that we have dropped off to the pediatric offices.
We need more.
We need more. Just let me know. Just call, and we can drop them off.
We're opening up our 4th office July 1, and I mean this year alone we will probably reach anywhere between 12 and 13,000 youngsters in the tri-county area here. Yeah, going into the schools, and we did the Special Olympics down in Otsego County and whatnot. I guess has the state, you talked about, I guess my concern would be, you had mentioned motivators for the parents, because that's essentially the people that you're talking about. Has the state ever thought about, because this is such, and I agree with you wholeheartedly, it is an epidemic. It's disgusting. We have Dr. Laura, you met Dr. Laura, she's our pediatric dentist, she's coming back from maternity leave in September. We have 120 full mouth rehabilitation children waiting to see her in the OR. 120 from the Tri-County area here. And has the state ever thought about doing something with benefits to ensure that the parents bring their children to the dentist?
Like the $50 gift card that they give?
No, not the $50. Not the $50 gift card. I'm talking about if you see the physician and the youngster has rampant caries or is at high risk, you have 60 days to bring your child to the dentist for a comp exam, or your benefits get reduced or cut off.
Didn't they just do that in Maine or something?
I'm just asking, because if it's such, and again, maybe I'm just kind of very forward saying this, but I mean,
I agree. Head Start forms.
Yeah.
It's the same idea, right? But it still is a nice idea. It doesn't always happen for all the kids. Yeah.
But if they don't, they fill them out and they take them to the school, but there's no follow-up. So these kids might have 10, 15 cavities, And then when they get to second grade, they have to fill out the form again, and they still have those 10, 15 cavities. And it's 100% covered by their insurance.
Right.
All you have to do is bring them in.
Yeah, I'm not saying, I don't care if they come to us, I don't care if they go to any, I just want them to get care. That's why we donate thousands and thousands of dollars a year in toothbrushes and staff services. And, you know, I just want them to see somebody, that's all that I care about. So how do I get in touch with all of the ladies and gentlemen in the room here to help with this? How do we do this?
So I don't know that I alone know the answer to that
well,
question.
I'm kind of asking everybody, you know what I mean? Like, I'm just trying to create a dialogue between dental and medical.
Where's your
That's
new
what we're here
office?
for, right?
July 1st, where's your new office?
Burton.
What's the youngest you take patients?
I mean,
Is it one or?
Dr. Ybarra, she did.
Is your requirement?
Okay.
Say again, that too. Yeah, exactly. And the thing is, it's not the kids; it's just talking to the parents. That's all that you know.
Yeah.
That's
so
what
I want to speak to two things that you brought up because I think they really are important in terms of systems and trying to really think larger than just one endeavor.
Yeah.
Head Start certainly does have a dental certificate requirement, which is separate from the New York State school system requirement. So Head Start requires that they get a dental, that they either have a dental care or that Head Start has to help facilitate access to dental care. So that's huge, right? Because that takes the burden solely off the family, off of the pediatrician just saying, here's your dental list, right? Here's a list of dentists in the area who take your insurance, which is something, it's necessary, but it's clearly not sufficient, right? So Head Start is helping with that. One of the pieces, and I spoke to this earlier, but not in depth, one of the pieces that I think is really woeful is that we could, from a pediatrician's perspective, if I'm seeing the child or any primary care clinician, I'm seeing the child and I identify them to be high risk, I put them in a bucket and we case manage them like we do every other health condition. It doesn't have to be every child who has a tooth who has to be case managed to go to the dentist. But if I identify them to be high risk, however I define that, our office defines that, however big or little a bite you can take out, how could we then begin to case manage that, put them on a list, a call or a phone call, or put them on, you know, the office list to call, or have a day where we meet in the middle, you know, those types of things, really building those relationships make a huge difference. And having the local providers know that you would see a kid on short notice who has a problem, right? You know, making sure that that open forum is there, and that pediatricians begin to really own their half of it, right? So we have to identify it, and we have to refer it, and we have to make the referral meaningful. And this is to your point.
It's tough for us, and maybe some of the physicians and staff in the room. We're, I think, one of the only offices in the county that do work with a lot of the managed cares. And so it's very difficult for us sometimes because, you know, I think we've established a pretty decent name for ourselves in the area, but sometimes it is difficult to get patients in, and we may be booked out till the end of July or August.
And then you book them and they no-show.
Ask for me, ask for Cammie, you know, because I want to get in touch with you guys as best we can in order to kind of establish this connection. And,
yeah, at least for those people that we identify.
Yeah, absolutely.
Really, you know,
absolutely.
You did speak to whether or not anything has been done to sort of make people do this. And the only endeavor that I'm aware of besides the dental certificate and the Head Start requirement, and it's a real requirement, so that is a little bit bigger of a bite that they took out than just this sort of token certificate that has to be given to the public schools. Two things. The first is that there is a local payer, I believe it was CDPHP, who tried an incentive program for, was it CDPHP? Somebody. Who tried an incentive program that if primary care people who actually received a small token sum if they actually were able to facilitate dental establishment for their kids.
For the referral.
For the referral piece of it, but the kid had to go, and then, you know, after so many months, you got $10 in mail or whatever it was. There was a whole bunch of problems with the way that rolled out, so it didn't really kind of get going before it fell flat, but it was a good idea. So it was making somebody own it, right? Who can own it? Head Start can't own every kid in the county, right? It's not fair. They don't have the resources for it. And, you know, they only see Head Start kids. And by then, they're 3 and 4. They're not 1 and 2. So who else can kind of own pieces of this problem? So that's been tried. And the other thing that I think is interesting when we think of it, the school-based health piece of it, there was recent legislation that passed in the city school board, and maybe this is something that Steve Jennings can think about, the city school board, where they now have an opt-out policy for dental screenings for children. Now this is school age, so it doesn't help us much with the early childhood care of these kids. But the school-age kids, previously it was opt-in, so you had to send a form home and parents had to sign for their kids to get screening. Right, how many people sent the form back? Not very many. But now it's an opt-out, so the family has to take the initiative to send the form in, or the child's automatically screened. And then as a piece of that, they've set up more school-based care and some more places that they can send these children. It's still incumbent upon the parent to get definitive care, but at least increases the screening of these kids. Again, that's a school initiative. So it really doesn't take us back to the little kids, but the little kids don't go very many places. So you got to meet them where they go. Home, Head Start, school, daycare, and physicians' offices, and hopefully the dentist. Did you have a question?
Yes. Do you know, is there anything available, like promotional material-wise, that could be put up in our offices or in our patient rooms? Like our patients will sometimes wait, half an hour to an hour in the room, looking around the same room, being bored. They've been in that room like 10 times. And if we had something that could be put up just as simple, did you know you're supposed to be brushing your teeth? Because we try to talk about dental health with everything else, but we're also supposed to talk about like plant safety and suicide safety and bullying and like a
Christmas tree ordinance.
In 7 minutes.
Like I totally get it.
Right.
Yeah.
So as you know, so I was just, if there was something we could put up in our 12 rooms that was by the state or by whatever that is, did you know you're supposed to be brushing your teeth?
That we don't have to print out,
once
they will mail to
once you
all
get to
registered.
2, right? And then did you know your child should be seeing a dentist by the age of 2? Because I mean, I had somebody the other day. Today, it literally was like a very good patient that had like 3 kids, and this was like her 3rd kid.
If you guys want something, I'll call my dental rep tomorrow.
That would be great.
And see if we can get some posters donated or something like that from them. The other thing too is I was down in New York a couple weekends ago at a conference. I was very nicely asked back to do a presentation, and one of the other ladies that was on a panel, Process, which is the toothbrush at Banco Dental, they're one of the big manufacturers. They've come out with an entire new line of pediatric dental cleaning tools, whether it be like little finger condoms that you go in there and you do your thing with.
We don't call them condoms.
I know, but I can think of it the other way. Sleeves, thank you. I can think of it. Different styles of pediatric toothbrushes, things to wean kids off of pacifiers. All sorts of different things that they had down there. So I mean, if you guys want literature, I'll try with them. Give me 10 days, and we'll see if we can get some stuff for you.
Did you have a comment?
So we, and Tina can chime in too, because oral health is one of our top priorities for our community health assessment. We are trying to procure funds to do exactly that, things that you might need, so we can help you. So Tina from the Perinatal Council, the council's kind of adopting the oral health initiative, so we're working on that. So that's great. And we can.
The other place that I would tell you free stuff, the AAP Oral Health Initiative has a bunch of office posters, information in multiple languages, as does Smiles for Life. So office posters, patient handout. Those 2 resources that I had there, somebody's already done that legwork and kind of put it all in one location, and to Cambodian. So you can be really very specific about it. There are videos you could put on. If you have an office TV, you could loop in. If you, I don't know how many of you have a media forum, little iPad things, that you can download little videos. The ADA has some video stuff like that. So there's certainly places that you can find it without feeling the need to recreate any of these tools. And there's some really good things that have been done, both in the city by the ADA and then the AAP and Smiles for Life.
Thank you. What's so unfortunate is that, there's not a ton of dental offices in the area, but there's a fair amount. And they don't see kids younger than 4 or 5.
Right.
And then they tell parents, okay, from what parents tell me, well, my dentist said he doesn't need to be seen until he's 4 or 5. School age. And I'm like,
we're hurrying again, and that was what I just asked Tammy, is that I feel kind of embarrassed, and because I asked her, I'm like, how did we even find out about this? And she's like, we saw it on the news. We didn't. So I don't know if the dentists were contacted in the area, But I'm glad we came. I'm glad that I found out about it because, you know, those of you guys who I have worked with, I mean, we try and be as involved in the community as possible and really try and working with the managed cares and trying to see as many patients as we can, as effectively as we can. I wish that there were more of us here. Yeah. And it's sad because as you were talking about silos, like dentists are, you know, I don't know what the deal is, and I feel bad. I really feel bad. But for a dentist to say that, you know, they shouldn't be seen until they're 4 or 5 is, I apologize because that's not. That's
and even if they don't want to see that, you know, even if they say, well, I'm sorry, you know, we don't see them that young, I'm sorry that we don't, but they should still be seen. But
one of the things that I think about in terms of workforce, and I know we're done long past done with our time, but thinking about if these general dentists in the area, you know, what could be done to kind of help them to understand a little bit more about how they could take on, you know, maybe lowering their age, and thinking about how the pediatric dentists who are specialists in child care management could help them be more comfortable to see some of these lower risk little kids. And that's not easy, just thinking in terms of trying to increase access for very young children. Not everyone's going to see you at age 1. So we got to think about what else we could do, and if maybe the general dentist, with some more collaboration with more pediatric dentists or more pediatricians in the area, we could do more bidirectional education and training and get them a little more comfortable with somewhat smaller children, even though they're not trained to do that in dental school.
It would be great if we could do with the varnish from teeth to age 3 to age 4, and then.
And I mean, we have access to, not only do we have Dr. Ybarra, who's our pediatric dentist, she's coming back in September. We work with 2 very amazing pediatric dentists, one down in Syracuse and then the Glens Falls Pediatric. Yes, it's a little bit of ways away, but they both work with different managed cares. So we have access to people who we refer to continually on a daily basis because she can only keep up so much.
Thank you.
So if you guys need people, just you know, we can help you refer. We can get you referral slips or whatever you want to do. Great. As I said, I don't care if you come to us, but just exactly just to be seen. That's all I care about.
This sounds like a conversation that is going to keep happening in the community, which is exactly what we want to have happen. Yeah. I'm going to close. If anybody has any other specific questions, I'll hang around in a few minutes. But I want to say a special thank you for spending the evening with us. And my hopes it is that this made it a little bit easier for you to begin to think about doing this.
Evaluations, don't forget evaluations.
Oh yeah, evaluations. Please, if you don't mind. And all of you who require CE should have received a CME. You can write your own name in it. And that way you can apply for a 1-hour CE with AA.